On this abdominal radiograph of a skeletally mature patient, the bowel gas pattern appears unremarkable with no evidence of pneumoperitoneum. However, there is a crescent of gas evident in the right hemipelvis, with additional locules of gas in the left hemipelvis. These gas patterns do not appear to lie within the bowel, which suggests that they are projected over the bladder. Given the location and appearance of the gas, this raises concern for the presence of gas within the bladder wall, potentially indicating a serious pathology. At this point, a number of differentials could be considered. Gas within the bladder can be secondary to recent catheterization, enterovesical fistula, or post-instrumentation. It's also possible that the gas is of rectal origin, but given its positioning and the appearance of the gas over the bladder, the leading concern is for intramural bladder gas. Given the patient's known history of diabetes mellitus, a more likely diagnosis in this scenario would be emphysematous cystitis. This condition is typically seen in older patients with diabetes and can range in presentation from mild urinary tract infection symptoms to severe sepsis. The appearance of gas within the bladder wall is a hallmark feature of this diagnosis, but it is often subtle and can be missed on plain films. A CT scan would provide further clarity and is considered the most sensitive and specific imaging modality for diagnosing intramural bladder gas. Considering the clinical context and imaging findings, emphysematous cystitis becomes the most probable diagnosis. The presence of intramural bladder gas in a diabetic patient with or without systemic symptoms would prompt urgent discussion with the referring team. Immediate management is crucial due to the risk of rapid progression to sepsis. CT imaging would not only confirm the diagnosis, but also help rule out other possible complications or coexisting pathologies, such as emphysematous pyelonephritis. In a VIVA setting, examiners might ask about differentials for gas in the bladder or renal tract. It's essential to acknowledge that gas could result from various causes, including catheterization, instrumentation, or even infections like emphysematous pyelonephritis. However, the localization of the gas in the bladder wall, combined with the clinical history, strongly points toward emphysematous cystitis. To wrap up this Viva, if you found this discussion helpful, don't forget to subscribe to Radiology Made Easy. If you've encountered similar cases or have questions, drop a comment below and let's keep the conversation going as we learn together.